Does it matter what order we give drugs in RSI? Let's talk about it. All right, everybody, welcome back to Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here. Danny, today we have an article from Academic Emergency Medicine talking about the sequence of drugs in RSI, because it turns out it might not matter. So we know in RSI that the ultimate goal is to sedate and paralyze someone before we intubate them. What they wanted to do in this study in Hennepin County is they looked from 2021 to 2024 with all patients undergoing intubation in the emergency department. Now, again, this is not an EMS study, but because we do RSI, we thought it was important. We see here, Danny, really good N, 2,200 patients. Most of them got etomidate and rock, and then they did all these adjustments here. This big conclusion is what we're going to talk about here. In this Bayesian analysis, as a paralytic first drug sequence was associated with reduced first attempt failure during emergency tracheal intubation. So that's a big wordy thing that can negatively affect some studies. Essentially what this found was if you paralyze a patient first before giving them a sedative, it increases first pass success. Now, what a Bayesian analysis is and why this is important, and where I think it gets really interesting, is Bayesian analysis is kind of a statistical tool where you couldn't really go out into the field and just say we're going to paralyze people before we sedate them, right? It's going to cause harm. We know that's not super ethical. So the way to figure out how to do this is by doing this kind of statistical tool, which is a Bayesian analysis. Bayesian analysis is a way of forecasting, where you have X amount of patients based upon history, and then you analyze whether or not giving these certain drugs in this order would have been more effective or more beneficial. There's a lot to really get into Bayesian analysis because it's a statistical tool, but it's a good way of analyzing something that you can't really otherwise research. That said, Dan, this isn't a perfect study because it's just statistical analysis, but it's interesting that paralyzing someone first achieves better first pass success than sedation.
Yeah, and if you think about it logically, with the time to effect of these paralytic drugs we use, whether you're using rocuronium or you're using sedation, it does take time for this medication to work. A common mistake in RSI or drug-facilitated intubation, whatever you're calling it in your shop, it's fine, is the fact that we don't allow the paralytics to work fully before we start that first attempt.
Right.
Hence, you could have somebody who's completely asleep, completely unaware, and not 100% paralyzed yet. And that's a problem when you go in and you try to distract the jaw or try to move tissue. You may not get the view you want. You may not be able to overcome that, and that leads to a failed attempt. Not good for patients, not good for everybody in the room. The tension goes up. We know that with repeated attempts, more problems occur and worse outcomes. So it may be smarter to give the paralytic first. The question is that ethically sound? And will it hurt the patient? Because the last thing we want is somebody who's completely paralyzed, but aware of what's going on.
Right. And we spent years teaching this in RSI classes, right? If you see someone tearing, they're probably conscious, but still paralyzed.
Hypertension, tachycardia, these things are...
Yeah, they're starting to buck the tube and all that kind of stuff. So it is an important thing to consider. I tend to think that high levels of sedation are important for RSI. I tend to kind of gravitate more toward the DSI side of things, where maybe if we take a patient and give them ketamine first, maybe that will relax them enough to be intubated. But one of the issues with this is we know the paralytics work, right? And again, in here, they just looked at rocuronium. They didn't use succinylcholine in a lot of in any of the studies. So it was pretty much just using rock. One of the issues with rock is that it's a long-lasting paralytic. So, you never want to necessarily give the paralytic before giving a sedative because you don't know if you can control that airway. So there's a lot of variables to kind of take from this, right?
Right.
Anytime you're going into an RSI, you want to make sure that the patient has an airway that you can probably control, right? You want to get a good, Cormack-Lehane score. You want to get a good Mallampati and see if you can actually get that airway. In these studies, or in what they analyzed here, they found that giving a paralytic opens up the airway a little bit easier than giving the sedative first, which is fine. I wonder how much of that, what the time delay was between giving the sedative and giving the paralytic. And I wonder if it would be possible to just give the sedative and paralytic, kind of a 1-for-1. If you establish bilateral lines, and give the ketamine on one side and give rock on the other side, there's a lot of variables to talk about here. The end result being that if it's easier to intubate somebody after you paralyze them, I do think that stands to reason, right?
Mhm.
If I have someone who has a clenched jaw and I sedate them, nothing's going to happen. So I think it makes sense. But I agree with you where there's an ethical concern as to how we could possibly move forward with this, right? Now that we have this information and we know that it's possible that paralyzing someone first might facilitate their airway, do we have a conversation about this temporary discomfort is going to lead you to better outcomes? So do we start talking about that with patient care and moving forward in a way where it might be better for the patient and not entirely great for them at that time? The analogy in my head is kind of like using a hair traction splint,
Okay.
right? Like you don't want to do any harm, but if you have someone who's got a midshaft femur fracture, pulling that fracture into traction can cause shearing forces, it can cause all types of different injuries. But our theory is that if we traction that femur and put it back in line, causing that temporary pain, we improve their outcomes in the field. You know what I mean? That's kind of where my question is do we take this information and do we apply it to clinical care while still saying, like, this is the way to do it? And we're still going to sedate the patient. We just want to sedate them after we intubate them. And then do we have sedatives that have appropriate retrograde amnesia to apply to those patients? You know what I mean? It's not, this isn't a simple thing.
Yeah. I get what you're saying on this. And I think most of the authorities on RSI, I'd love to hear what they think, but I think the way the books talk about it and the stuff that I've studied, classes I've taken, they want that induction agent and that paralytic given as close together as possible. So when
Right.
you're in there and you're the airway medic and you're looking at your partner who's going to push these meds, the way they should be pushed is induction agent, unscrew the syringe, go right to your paralytic, push the paralytic. Now make sure you're oxygenating, wait for that relaxation to occur, and then get the tube. In that
Right.
case, I don't know what the benefit would be to paralytic first, but the biggest thing to remember here is you have to let that paralytic work no matter where you give it in the sequence. And these things take 45 to 60 seconds in a normally hemodynamically stable patient. In an unstable patient or a sick patient, you're going to see that it might even take longer. You may even need stronger doses of your paralytic to get full neuromuscular blockade. All
Right.
these things are things to think about and discuss with your medical control physician, discuss with your clinical people or your medical director.
And it may be like we talked about how long it takes for rock to work. Rock can take 60 to 90 seconds to work. So it may even be that administering a paralytic and then knowing that it'll take 90 seconds to work and then administering something like ketamine, which takes 30 seconds to work. Do you give the paralytic first in that sequence? The patient still achieves analgesia and sedation, right? But you're just giving it at different times and they'll both kind of work at the same time. You know what I mean? So, and this is one of those problems where, and this is one of those things where it also comes down to individual patient metabolism, individual patient presentation. The nice thing about this data set is that it's kind of a ground level, right? Here you go. This is the basis. It probably doesn't matter what order you give the drugs in, but we know that giving the paralytic first is associated with improved first pass attempts. That's all this study looked at.
In this
study, but we can take this study and say, all right, here's a decent N that says that giving the paralytic first improves first pass successes. You then go back to your system and see how your systems are working, right? Do you often give the sedative first and then the paralytic? Are you doing RSIs where you give the sedative and then you're giving the paralytic 2 minutes later and then you're RSIing 4 minutes later? You know what I mean? So having this type of information can really be well used going back to your systems and seeing how you're doing compared to what the available data is. And then you go back to your providers. What do you see? Do you see trismus in the field before you give these medications? How does our sequence work? What can we do to improve? But we are curious, as always, as to what you guys think. Do we want to give a paralytic before we give a sedative? Again, it's kind of controversial. I can understand the ethical concerns behind all of it. We want to hear what you guys think. Check us out on Apple Podcasts, YouTube, Spotify, EMS One for all of your EMS news needs. And for the Overrun, Ed Bowder, Dan Schwester, we will talk to you all next week.